Dear colleagues, my name is Steffi van der Ven and I'm a research physician at the Department of Gastroenterology at the Erasmus University Medical Center in Rotterdam, the Netherlands. On behalf of all the co-authors, I would like to thank Endoscopy for the opportunity to discuss the results of a recently accepted manuscript titled Individual Risk Calculator to Predict Lymph Node Metastasis in Patients with Submucosal Esophageal Adenocarcinoma, a multicenter cohort study. There is a risk for lymph node metastasis after endoscopic resection of early esophageal adenocarcinoma. Histopathological risk factors associated with lymph node metastasis are the presence of lymphovascular invasion, deep submucosal invasion, and poor tumor differentiation grade. Although many studies have described these risk factors separately, no appropriate clinical tool is available that incorporates all accepted prognostic histopathological parameters to accurately predict the lymph node metastasis risk on an individual basis. The aim of this study was to develop and internally validate a prediction model based on histopathological variables that estimate the risk of lymph node metastasis or distant metastasis in individual patients with T1b esophageal adenocarcinoma. This is a nationwide retrospective multicenter cohort study that was conducted in patients with T1b esophageal adenocarcinoma treated with endoscopic resection and/or surgery between 1989 and 2016. The primary endpoint of this study was the presence of lymph node metastasis in surgical resection specimen or detection of metastasis during follow-up. All resection specimens were histologically reassessed by specialist gastrointestinal pathologists. A total of 248 patients with T1b esophageal adenocarcinoma were included in this study. Metastases were seen in 78 patients, and the 5-year cumulative incidence of metastasis was 30.9%. Multivariable analysis showed that deep submucosal invasion, the presence of lymphovascular invasion, and larger tumor size were associated with metastasis. The probability of developing post-resection metastasis was estimated with a personalized predicted risk score incorporating tumor invasion depth, tumor size, and lymphovascular invasion. This risk ranged between 5.9% and 70.1%. To conclude, a personalized risk could be predicted based on the presence or absence of each histopathological characteristic with good discriminative ability of the prediction model. Deep submucosal invasion, the presence of lymphovascular invasion, and larger tumor size were poor prognostic factors for metastasis. This prediction model requires external validation before implementation into clinical practice. Future research should perform external validation of this prediction model. I would like to thank you for your attention.